Thank you, Megamind, for hosting this wonderful event, and thank you, dear judges, for your valuable time. It's such a great honor for me to be here doing this presentation today. And a little bit about me. I'm Dr. Esmond Siagian. I'm a periodontist and implantologist from Jakarta, the capital of Indonesia. And today I want to share my presentation about Plan Before You Plan, Peri-implant aesthetic management for predictable outcome. Let's start. What is aesthetic? In general sense, aesthetic refers to the branch of philosophy dealing with the nature of beauty, art, and taste. Aesthetic is about balance, harmony, proportion, symmetry, contrast, and unity. And is this harmony? Is this balance? Back in the day, many years ago, where I started doing implant in aesthetic case, I began to learn about bone grafting around the implant and soft tissue augmentation, but I end up with these results. Recession on the gingival margin, uneven margin line, loss of interdental papilla, etc., etc. I could not find the proportion, harmony, and balance in these results. It was so difficult back in the early years, sometimes make me very stressful when the patient came to the office and want to get implant treatment in aesthetic area. And what about today? Let's see example of this aesthetic dental implant case. After evaluation, we need to extract and replace tooth number 12, 11, 22, and 23. How to put dental implant in this patient? How do I handle aesthetic implant case now to prevent failures like the case in the previous slide? The first question came to my mind before doing implant placement would be where to put the implant fixture. But before I decide to put the implant fixture, I should first plan where the final soft tissue margin line will be. And if you can see the imaginary line, the yellow line, is this yellow soft tissue margin line really good enough? Maybe yes, if we only see this picture. But when we try to zoom up and try to see the bigger picture, this yellow margin line is slanted because the patient already have a canting smile. We need to achieve new soft tissue margin line for this patient. So seeing bigger picture is the first step and important for aesthetic case. So this is why plan before you plan. Before we insert the implant fixture, we must plan where the future margin of the implant restoration. This is really important because you don't want to have case like this without planning, without doing a proper implant and scratching your head trying to figure out how to restore implant like this with recession this much. And to plan it, we must understand what kind of implant margin therapy and what kind of provisionalization that we will discuss after this. Like Benjamin Franklin once said, if you fail to plan, you are planning to fail. If you fail to plan your implant, you are planning to fail in your implant case. And today I want to share my thought and story how I developed the strategy and got more predictable and stable outcome. I will discuss three main topics today. It's about the soft tissue margin, provisionalization, and the fundamentals. And to describe about these three things is the soft tissue margin therapy. And then the second one, the provisionalization, would be the type of provisionalization that we will use. And the last one is fundamental about the perio-prosthodontic fundamentals. You can find this framework in the article, a beautiful article published by Dr. Jonathan Esquivel et al. About timing implant provisionalization, which discuss about the fundamentals for tissue conditioning and stability. Let's start with the soft tissue margin therapy. It's only two, which is preserve or reestablish. Preservation is when we don't need to modify the margin outline, and reestablish is when we need to modify the margin and contour to get the ideal final results. Preservation is only when the ideal tissue outline is already exists, and thick phenotypes, and we don't need to do connective tissue graft during the immediate implant placement, and their provisionalization strategy involves a passive full contour provisionalization. This case with preservation therapy is very simple. It's quite simple, but very rarely. Maybe for me personally, less than 20% of my aesthetic patient is only preserved. Most of the time, I do the margin reestablishment therapies. While in margin reestablishment therapies, we have another story. We have delayed implant case, which is case presenting bone dehiscence with or without recession. The second one is the immediate implant sites with apically positioned gingival margin. So we need to move the margin more coronally. The third one is with the coronally positioned gingival margin. So we need to move the margin more apically. And the last one is when we already have an ideal tissue contour, but with thin phenotype. So we still need to modify the phenotype to minimize the risk of recession. And we can continue to the provisionalization, which contain of three categories, which is passive, active, and subcontour. And the difference between them is their relationship in their emergence profile with the underlying tissue, which may promote apical, coronal, or no displacement at all. To better understand about this, and I believe many of the doctor before me already discussed about this, is about the EBC concept. Just this year, Dr. Ramon Gomez Meda, Dr. Jonathan Esquivel just published a new concept, the 2.0 concept about the EBC concept. And from that, we understand that we must have three zones, the crestal, bounded, and aesthetic. But to make it simple, the crestal must be as straight as possible. The bounded should be as concave as possible. And then the aesthetic should be as convex as possible. And after understanding this, the crestal, bounded, and aesthetic, after refresh our memory about that, I want to continue to the provisionalization. First is the passive full contour provisionals, where the restoration E-zone and margin line set at the level of the ideal zenith point. So without exert pressure on the underlying tissue, preserving the existing tissue outline is the primary objective. So this is ideal for the preservation therapies. And again, this is a very rare case, not very rare, but very rare case. Many times we cannot use this passive full contour provisionalization. The second one is the active full contour provisionalization, used to reestablish the future ideal gingival architecture to move tissue more apically. So we put pressure on the E-zone, and the ideal zenith point will move more apically because we put exert pressure on that area. And the last one is the subcontour provisionals. We use this if we want to move the margin more coronally. The subcontour provisionals are passive provisionals, as their zenith and E-zone are set coronally to the ideal position to allow space for soft tissue creeping and grafting, and this is ideal to move the margin more coronally. Why I only talk about provisionalization? I don't talk about the stock healing abutment, because nowadays we knew that we need to put the implant fixture more palatal to leave space for the tissue and to be able to have a screw retain restoration. But if you use stock healing abutment, you can see how big the gap at the labial side. The tissue will have no support, and soon it will collapse, and we will lose all the advantage of doing immediate implant placement. So this is how stock healing abutment, in my perspective, in aesthetic case. In peri-implant aesthetic management, the use of provisional restoration will give the most ideal outcome compared to the stock healing abutment. And the last one is the perio-prosthodontic fundamentals. We can divide into three categories, which is space, volume, and time. I believe we already understand about the space, which is the implant 3D position and the material selection, etc. The volume is about the bone and soft tissue phenotypes. That will decide when we need bone grafting or soft tissue grafting, or instead we need to do gingivectomy with or without ostectomy. And the last part is the time. Time is osseointegration time and soft tissue integration time. And time is what I don't have now, only 50 minutes. So maybe next time I will dig deeper with this discussion. Now I want to share to you what is the results if you put the implant ideally based on the concept that I already discussed. In one of my clinical case, this 48-year-old female patient came to my office. She wanted to improve the condition of her teeth and want to have a fixed restoration. And this is the initial condition of her teeth. It will be easier if we do orthodontic treatment first, but the patient refused for ortho. And another reason is because the patient lived far away, around 2 hours from her place to my office. And also, maybe it will be easier if we do just extract all the teeth and do all on X on the maxillary region. But the patient is 48-year-old, is still middle adulthood. We need to preserve the remaining teeth as long as possible and only extract the unrestorable tooth. So because the subgingival caries and the remaining roots on the tooth number 12, 11, and 22 and 23, we extract the four of that tooth, and because the limitation of the mesiodistal space in 11 and 12, we decide to put one implant in tooth number 11, cantilever pontic in tooth number 12, and immediate implant on tooth number 22 and 23. So let's start with the framework that we already discussed. This case is immediate implant sites with coronally positioned gingival margin. So what is the scenario for our patient? The soft tissue margin therapy will be re-establishment therapy because we need to establish new soft tissue margin. And the provisionalization will be active full contour provisionals to move the soft tissue margin more apically, more upwards. And before I start, of course, I talk about plan before plan. So I plan very carefully following the digital smile design. We plan and design the surgical guide for implant and gingivectomy. We have opted for the gingivectomy without ostectomy because we can see from the gingivectomy guide, the guide doesn't intervene with the bone. Even after we do the gingivectomy, there's still leave a good soft tissue before it touched the hard tissue or the bone. And then the day of the operation, we do gingivectomy guidedly to achieve optimal results. And then only after the gingivectomy is finished, we do the extraction. And then we change the guide to surgical implant guide and insert the implant fixture guidedly, at least 4 millimeters from the fixture of the margin line vertically. This is the reason why we do gingivectomy first, not after the implant placement. Also, the implant fixture position is measured 4 millimeters horizontally, and we put some biomaterial, which is allograft in this case, for grafting the labial bone gap. But unfortunately, we cannot get the ideal insertion torque for tooth number 22 and 23. But for the tooth number 11, we get good primary stability and continue right away for immediate provisional restoration. So this is gonna be the picture that we only see about the tooth number 11 and 12 because that's it. After we understand about the EBC concept and the workflow, this is all what we do on these tooths. And just make sure it accordance to the EBC concept and relieve the contact on the incisal area. And for the pontic, I have no time, but the framework I choose for the pontic design, but due to time limitation, I cannot discuss deeper about this. And then 3 months post-op, we do re-entry for the tooth number 22 and 23 to put the new provisional restoration by making the labial roll flap first to push the flap more labially, and then insert the PMMA crown. As you can see, the margin line is not that very good, but don't worry, we can still modify the active full contour provisional. We put again some pressure on the margin line so we can move the provisional restoration to move the margin line more apically and get a more aesthetic results. And then this is 6 months post-op and before taking the final impression. This is the emergence profile 7 months after the operation. And the time of the delivery of final crown restoration, again, following the ABC concept of the final crown restoration. And this is immediately after final restoration. You notice there's still lack of papilla head, redness at the crown margin, but be patient and trust the polyzirconia restoration. Give it time to fully heal. And the final results, 8 months post-op, we can see the contour is really, really good now. And this is the peri-apical X-ray. There's no bone loss. And then this is the final result, 10 months post-op. This is the emergence profile before and after. And intraoral before and after. This is the extraoral before and after. The patient really, really happy for the result that she got. So aesthetic, function, and biology combined will shape your final results. Like Albert Einstein said, everything should be as simple as possible, but not simpler. As simple as possible, as complex as necessary. For the conclusion, plan before you plan, understand about the EBZ zone and peri-implant biology is essential, and understand about the perio-prosthodontic fundamentals. Terima kasih. Thank you very much.